So welcome everyone to this Australian Prevention Partnership Centre End of Project Symposium. My pleasure to be able to introduce this session today. In starting, let me acknowledge the traditional owners of the lands on which we variously gather and recognise elders past, present and future. So the Partnership Centre has had over its years of research a number of projects looking at how we can better implement prevention within the primary healthcare space. And today we're going to hear about a specific project about how we use the PHN systems to implement revised CVD cardiovascular disease prevention guidelines. And the work that's been done in that area. Interestingly, I spent part of the weekend in Coffs Harbour at a meeting with local PHN talking about issues. Many of the issues were around how to better do prevention within primary care, within general practice, and a particular focus on issues there. And you'll hear some of the issues that were identified that came up within that meeting here today in the work that's been done. And it's really my pleasure to introduce to you Dr. Carissa Bonner, who's a Senior Research Fellow within the Menzies Centre here at the University of Sydney, as well as being a Deputy Director within the Sydney Health Literacy Centre, which has been doing a lot of great work in this space. Carissa has a fantastic track record of research around the overlap between health literacy and implementation of guidelines, particularly in the cardiovascular disease space. She's been working with Sam Cornell, who's a researcher also within the Sydney Health Literacy Lab, and this is a great example of some of the broader work that the Health Literacy Lab has been doing in this regard. So with that introduction, let me hand over to Carissa and Sam so you can hear about their work in the implementation of the revised cardiovascular disease prevention guidelines. Over to you, Carissa.
Thanks, Andrew. And thanks everyone for joining. So I'm just going to start with a bit of an overview of what we'll be talking about today. So I'm going to give a little bit of background on the guidelines that we're talking about, but also happy to answer any more specific questions at the end about what's happening with the revision of these guidelines, but I won't go into that too much at the start. And then we're going to go through some of the findings from a program of research that was funded by the Prevention Centre, 5 different studies looking at both PHN and GP perspectives on how we might use PHN programs and systems to better implement CVD prevention. So I'm going to do the background and then I'll hand over to Sam, our research officer on this project, who really led the first few studies in this program of research under very challenging circumstances during COVID lockdowns and outbreaks all over the place. So he'll present the first 2 studies which have been published, and we'll provide links to those as we go through if you want to find out more about that. And then I'll present some other work on a series of opportunistic case studies we ran in PHNs in between COVID disruptions. So it wasn't quite as systematic as we would have liked in our original proposal, but we were still able to do some really interesting work testing the feasibility of different implementation strategies in PHNs and in general practice. And then our final study was a collaboration with the IDEAL study team at the University of Tasmania, who've been working with the PHN there to look at some really novel ways of implementing CVD prevention guidelines through pathology centres. And we had an opportunity to work with them on some GP interviews to look at more general support needs and how PHN programs might fit with that. So all of that will take up about half the time, and then we will have plenty of time for discussion and questions at the end if you'd like to know any more details. And we also have a briefing report that outlines the key findings of these studies that we can send to you as well. So we've been looking at this issue of heart disease risk assessment guidelines for about 10 years. So they first came out in 2009 in Australia, where we moved from an approach of managing individual risk factors, so blood pressure and cholesterol, as very separate things. We moved from that to an absolute risk approach where we combine all the most predictive risk factors, including things like sex and age, to come up with an estimate of the chance of having a heart attack or stroke in the next 5 years in this case. So some countries use a 10-year model. We've been using a 5-year model. But they all essentially do the same thing in that they're trying to more accurately predict who is at high risk and most likely to benefit from taking preventive medication for blood pressure and cholesterol. So in our current guidelines, which are currently being revised, we have been using the framing and risk model, which is the US-based model, where we have defined high risk as being 15% chance of a heart attack or stroke over the next 5 years. So when this first came out, this was the original risk calculator. It looks a little bit different now, but it was essentially you put in these risk factors, it will give you a number, and that was in theory supposed to guide management. But the management guidelines didn't come out for 3 years after the risk assessment guidelines. So there has been a little bit of a mismatch between the assessment guidelines and what you're supposed to do for management. So there were also some printable versions of this, a bit more of a rough risk assessment that could be used in practices that maybe didn't have access to these risk communication tools, risk calculator tools when they were first released. But it has sort of moved more towards a calculator model in practice over the last 10 years. So we've been looking at this issue from a shared decision-making perspective, where we started off just interviewing GPs and patients about risk assessment, and our original intention was actually to see how they monitored risk over time. But what we found in that first set of studies, which was published in MJA 10 years ago now, was that the risk assessment wasn't actually being done in line with the guidelines in the first place. So we couldn't really look at the monitoring because the assessment was so variable. So what we found was that there were issues in each aspect of this model. In terms of evidence-based medicine, just the wrong way. We found that GPs were having issues with not having time to read and apply these, at the time, quite new guidelines. And as we went over the last 10 years, those guidelines became out of date and GPs didn't have time to necessarily read and apply the latest evidence that was coming out about interventions. On the patient-centred communication side, we know that up to 60% of Australians have low health literacy and they need more support to understand and act on information about their risk. And the communication tools that were available to GPs for most of that time weren't sufficient for explaining this quite complex issue to patients. So when we spoke to GPs early on, they were saying that when patients had low health literacy or they perceived them to have low health literacy, they sometimes avoided the risk assessment altogether because it was taking too long to try to explain this concept to patients. So there are evidence-based tools that can address both of these issues, particularly decision aids. There's over 100 trials showing that these work to explain complex evidence-based information to patients in a way that helps them engage in informed decision-making. But in Australia, there's no one repository where up-to-date decision aids are available to GPs. So there's very variable access. Some of our early work actually reviewed all available decision aids in the CVD prevention space. And although there were quite a few internationally, none of them matched the Australian guidelines. So GPs didn't have access to these tools when we started this work. So all of this is contributing to this issue of suboptimal patient care, where we knew that around 17% of patients in the eligible age were actually having their risk assessed. There have been more recent estimates of that are closer to 50% for practices that have engaged in the quality improvement programs funded by the federal government more recently. So we have maybe improved, but there's still a long way to go to implement this approach systematically. And at that time, we also had some data indicating that only 44% of patients were actually being managed according to the guideline, meaning that if they're high risk, they are given preventive medication. So we started off talking to GPs and patients, reviewing what tools were available to help some of these issues. And because we didn't find any that would fit the Australian context, we developed our own. So this is the ChatGP disseminate. It's essentially just an interface for the current guidelines that more quickly integrates the assessment and management guidelines in a way that meets best practice risk communication. So instead of just giving a percentage result, it uses this icon array format. So there's been lots of research to show that this type of format helps patients make sense of an abstract probability, but it also gives GPs a way to really quickly see what the recommendation is in the full website. So for this person there at 16% risk, it's considered high risk. And the diagram shows that what this means is out of 100 people like them, 16 would be expected to have a heart attack or stroke in the next 5 years. And what that allows you to do in a consultation is to talk about your intervention options in a more meaningful way for the patient. So for this particular person, if they took cholesterol medication, we'd expect their risk to go from 16% down to 12%, meaning that we're saving 4 heart attacks or strokes out of every 100 people like this person. So this type of interactive tool was co-designed with GPs and patients, and it was tested in various studies to show that it actually could improve knowledge amongst both the GPs and the patients so that they could implement these guidelines more quickly. But once we finished that body of work, we knew that that wasn't going to be enough to just have a research-focused website just sitting there, and we needed to look more into how we might actually implement a tool like this more systematically through existing systems. So that's been the focus of our last few years through our funding from the Prevention Centre. So our first stage in the implementation phase of this work was to talk to lots of different stakeholders. We have a partnership grant with the Heart Foundation and the RACGP, and we initially set up a network in Queensland with the 7 primary health networks there. So before COVID, we were all set up to do a big implementation trial. And we'd recruited our first practice when we went into lockdown. We tried to revive it a few times in different states that didn't have COVID outbreaks, but each time COVID sort of thwarted it. So we kind of shifted our focus to primary health networks nationally to see if the Queensland model would work in other states, and to sort of do what we could during COVID to inform the implementation of the new guidelines, which are due out next year. So what we sort of realised early on was that primary health networks were a really key stakeholder to involve in this process in terms of implementing funding models, but also general practice support in lots of different ways that we'll illustrate through this talk. So I'm going to pass over now to Sam, who led the first 2 of these studies, and I'll just find the control. Oh, it is showing everyone.
I'll request control, Krista.
Oh, it's okay. I found your name.
Oh.
You've got it.
I do have it, yeah. So, hi, everyone. To gain a clear understanding as to how PHNs think about CVD absolute risk assessment and CVD prevention more generally, we first looked at all publicly available needs assessments. So this included 31 needs assessments from all PHNs across Australia. The study aimed to understand whether PHNs are recognising the need for prevention of cardiovascular disease by investigating what local health and service issues they had identified and prioritised, and what activities they were going to conduct based on their needs assessments. So we conducted this study in collaboration with other Prevention Centre researchers, Simone de Morgan and Pippi Walker, who were conducting a project around prevention of chronic pain. However, in this presentation, I won't cover the chronic pain aspects of the study, but for those who are interested, they can see the paper published in the Australian Health Review, and I've put a QR code at the end of the slides for access to that paper. And also, I think Pippi and Simone are in this webinar, so you could pop some questions into the chat if you wish to talk to them about that. So cardiovascular disease is the leading cause of mortality and disease burden in Australia, and PHNs are well placed to address this burden as commissioning bodies and supporters of primary healthcare services. As part of the PHN commissioning framework, all PHNs conduct regular needs assessments to assess local health needs, local service needs, and identify opportunities where priorities and consider options to include in their activity work plans. Health issues relate to the health status and needs of individuals, populations, and communities, and service issues relate to each PHN region's service and health infrastructure. However, it was unclear to what extent PHNs were identifying local issues that relate to cardiovascular disease and whether the need for prevention was being identified, and if so, what data sources were supporting those findings. Therefore, the aim of this study was to understand the health and service issues, including prevention-related issues pertaining to CVD, identified in PHN Needs Assessment reports. Understanding the gaps and issues identified enabled us to highlight opportunities for PHNs to better address the primary prevention of cardiovascular disease. So the study utilised a qualitative document analysis approach of needs assessment reports for all 31 PHNs published in 2018 to 2019. And we searched for keywords within all these reports, including cardiovascular, CVD and heart, excluding congenital and rheumatic heart disease. The relevant text surrounding the keywords was extracted, processed and synthesized to report the number of PHNs that identified the health and service issues related to CVD, the types of issues that were identified and the data sources used, and whether risk factors or the need for prevention activity was being identified. So fortunately, almost all PHNs identified health issues related to cardiovascular disease. However, service issues were identified by less than half of PHNs for CVD, but the need for prevention of cardiovascular disease was recognized by most PHNs. Only one PHN did not identify any issues that related to cardiovascular disease. In terms of the types of the issues identified and supporting data sources, the most reported issues were mortality and potentially preventable hospitalizations linked to CVD and the prevalence of CVD. Health issues were frequently supported by National Health Survey data, general practice and also hospital data, whereas service issues were largely identified through stakeholder consultation. The main gaps identified were the relatively low number of PHNs identifying service issues related to cardiovascular disease. There are now a number of financial incentives for CVD prevention activities, such as rebates for heart health checks and also a quality improvement practice incentive payment to encourage the measurement of the proportion of patients with CVD risk factors. Specifically relating to health service issues, we found that this was largely supported by stakeholder consultation. Information reported by some PHNs included the method of engagement, so for example, surveys or interviews, when the consultation occurred and the types of stakeholders engaged, such as clinical and community councils and healthcare providers. The number of stakeholders consulted was less frequently reported, and no information on the questions asked was identified. Overall, we found that the breadth of stakeholder consultation was limited. So to address this gap, there should be more resources dedicated to stakeholder consultation to allow for increased participation from the local community and healthcare providers, which would allow more service issues to be identified. So in conclusion, although PHNs are constrained by government priorities and funding, greater stakeholder consultation is one potentially promising strategy to overcome local data gaps to identify and prioritise CVD prevention. Regarding the limitations of this study, publicly available core needs assessments may not be a comprehensive summary of all health and service issues identified by PHNs, although some PHNs publish conditional population-specific needs assessment reports, such as mental health reports. We did not review these. Lastly, this study did not examine whether health and service needs were actually prioritised. Although more PHNs identified issues concerning CVD, further research is required to understand whether this translates into activity focused on the prevention or the management of CVD. And you can find the link to the paper with this QR code here. So we next conducted PHN staff interviews. We based the interview schedule on the information we'd found from the needs assessment study. We undertook 29 interviews with 32 PHN staff from 19 PHNs. Around 2/3 of these were managers and 1/3 were practice support officers. So to recruit staff for the PHN interviews, we used a snowballing recruitment methodology, which involved utilising our professional contacts in this space and then asking interviewees if they would be able to put us in touch with any other PHN staff members. This worked quite well considering it was COVID and there were lots of disruptions in the health space. But COVID was also quite useful as it meant that the staff we interviewed were working from home a lot of the time and were effectively utilising tools like Zoom. We used a propositive sampling method to gain a useful number of and type of participants, and we analysed the transcripts using framework analysis, which enabled us to develop the main themes that came up during the interviews. So the three main things that we identified were that the role of PHNs in prevention was determined to be informal, that PHNs are constrained by the financial incentives set by the government, and that work is shaped by competing priorities. So for informal prevention, all respondents agreed that the role of PHNs in prevention was indirect and for the most part outside of the formal remit of PHN key performance indicators. Prevention activities were conducted in partnership with external stakeholders, professional development and quality improvement programs, and PHN-funded data extraction and analysis software for general practice. In terms of being constrained by financial incentives, most interviewees felt that the role of PHNs in prevention was contingent on the financial drivers provided by the Commonwealth Government, such as Medicare funding and national quality improvement programs. And the role of PHNs in prevention was determined to be a function of their other competing priorities. There was strong agreement amongst participants that the myriad competing priorities from the government and local needs assessments impeded prevention activities generally. I think I just skipped ahead quite a lot accidentally.
That's okay. I think it's a bit delayed.
Yeah. Yeah. So many responses reflected the idea that PHNs did not exist to implement prevention activities within general practice. Many staff we interviewed did not see it as their role to increase prevention within general practice, but many did explain that they thought that PHN should place a greater emphasis on prevention. Overall, the role of prevention in PHN activities was described by PHN staff as being quite informal, and they acknowledged that prevention was outside of their remit in most of the activities they were doing with GPs. One interviewee said, "We don't do enough health prevention or preventative medicine. We do a lot of chronic disease management, but we just don't do enough prevention." Interviewees acknowledge that PHNs are not specifically funded to undertake prevention activities at all, and that prevention is generally just not in their remit. Regarding the heart health check, one interviewee said that the 699 doesn't pay as much as other health checks that the GP could bill for. This has led to a lower uptake of the item than was hoped for. And interviewees described numerous priorities that were deemed to be of higher importance than working on prevention. At the time of our interviews, COVID-19 and emergency response measures were viewed as a higher priority than other activities, including CVD prevention. Interviews explained that priorities are many and change rapidly. One explained, just by the nature of the outcomes that we're supposed to reach as a PHN, whatever we do is only ever within that funding period going to be contributory to an overarching improvement in X number of years' time. So we identified four main implementation pathways to think about when implementing new CVD guidelines. These included capitalizing on the internal roles of PHNs, including practice support officers, conducting more GP education events, engaging further in quality improvement programs, and integrating more effectively with GP clinical software, which we'll go into further in this webinar. So regarding internal roles, one of our participants said we have to see all of our practices within a certain period. Once you are finished seeing them in that cycle, you start again. So we can capitalize on that in the relationships that have been built by those practice support officers and those GPs. And in terms of GP education events, participants told us they do quite a lot of education events in which they do clinical updates, which could be whole day events or evening. And these could be capitalized on to increase CVD prevention with GPs. And lots of participants talked about the financial incentives for GPs to work in areas that they wouldn't have previously thought of because of the quality improvement programs. So to conclude, our interviews reveal that individuals in PHNs do deem prevention to be a high priority, but they are constrained by the barriers of funding and competing priorities. We identified prevention activities being addressed indirectly by PHNs, which was dependent on financial drivers and competing priorities. PHNs are positioned to foster prevention activities in general practice in local communities, but this could be improved if supported with a more explicit prevention focus at the federal government level. And a link to the paper we did is here, the QR code here. Yeah, and Chris, I think I'll hand back over to you.
Okay, would you be able to, can you relinquish your control somehow? Yeah, thanks. Okay. So following on from identifying those 4 key implementation strategies in the interviews, we planned to actually test out those implementation strategies using our decision aid as an example or case study of how you might implement the risk assessment tools for the new guidelines when they come out next year. So ideally, we would have done this in a more structured way as part of an adaptive trial, but because of COVID, it ended up being more of an opportunistic series of case studies when PHNs had capacity to involve us or work with us in these different strategies. So we sort of divided it roughly between lower resource implementation strategies, including working with those GP liaison roles and education events, and also putting passive links into existing clinical software called Health Pathways. So that was a relatively low resource from our perspective way to implement some strategies in a way that didn't actually take much more resources on top of business as usual processes within the PHNs. Then we had some more what we called high resource implementation strategies, which involved using clinical audit software. So although PHNs often provide these licenses to practices already, it involves some practice-specific or app-specific development of reports and integration with medical records, so a bit more cost in terms of staff time and also software development, as you will see. So we've roughly divided it into those two because there's sort of some easy wins you can get out of the low resource strategies if you work with the existing systems, but there's also some high resource strategies that could be considered or systematized to make them lower resource in future. So I'm going to go through each of these implementation strategies and how we as a small research group were able to actually use these strategies to implement to some extent our decision aid into national programs. And just keeping in mind that the purpose of this is to show the feasibility of doing this on a scaled up level when we come to implement the new risk assessment tools for the new guidelines. So starting with our lower resource options, it's relatively easy to find out what PHNs are doing around GP education. So the example that we used for this series was we worked with Western Victoria PHN. They usually hold an annual GP update day or conference where GPs can participate for continuing professional development points. So we were originally set up to do that in the first year of COVID and it was cancelled. And then they ran an online version of it the following year that we were able to participate in. We just put together a 1-hour workshop that explained the current prevention guidelines, new directions that guidelines were taking in other countries that might inform our new guidelines, and we gave a demonstration of our decision aid tool as part of that. So that was not much work on our part, it was part of what the PHNs were already doing. So I guess the downside of that strategy is you have to do it 31 times to cover all of the PHNs in Australia, but that would be something that could be coordinated with a bigger implementation strategy for the new guidelines. Queensland is also an interesting case study because they seem to be a little bit more connected in terms of their GP liaison roles. So they have a really well-established GP liaison network. They have regular meetings and newsletters that we were able to be part of to talk about our trial that didn't end up going ahead. But that was sort of an easy way to connect with all 7 of the PHNs at once and hear their perspectives about the different regional issues that came up. So sometimes it was quite different what was happening in, say, Brisbane or Gold Coast compared to Western Queensland, where they're trying to cover a much larger geographical area with a smaller amount of money. So that was really interesting to connect with them. And that's a way to sort of, I guess, bring in some efficiencies in your education approach if you can connect with bigger networks across PHNs. So also considered low resource from our perspective was the use of health pathways. So for this, we worked with a New South Wales PHN who we happened to already have connections with, and we knew that they were updating their CVD risk assessment and management information in the health pathways. So they'd already employed a GP writer or allocated time for the GP writer to review this pathway because the MBS item for heart health checks was changing. So we were able to just work with their timelines, provide them with a very short description of our decision aid website and integrate that link into the pathway. So they very kindly shared their uptake data over 2 years with us, just so that we could see what would happen with that pathway over time. So this was started back in October 2019, so pre-COVID, and the uptake was fairly low. Once they added the MBS item and decision aid information, they did a little bit of promotion, not extensive, but just promoting through their newsletters, and their use jumped up a bit, and it more or less stayed the same over a long period of time, with the exception of Christmas and COVID lockdowns. So that's quite an easy thing to do, to integrate with different health pathways when the new guidelines come out, and it should sort of sustain itself over time without much further input. So the really interesting thing about the health pathways was that we only actually worked with one PHN initially, and we did see a jump in our own Google Analytics for our website, almost double within a month. But over time, as we sort of engaged with other PHNs, we noticed that we were getting more referrals from lots of different PHNs, including ones that we didn't have any specific involvement with. So altogether, over 2 years, we ended up having about 600 referrals across 4 states, and even from New Zealand in one case. And if you look on the right here, this is from our Google Analytics. You can see that our top referrer is actually Melbourne Health Pathways, and that's not a PHN that we actually actively engaged with. So again, as a low resource option, this seems like quite a good option to sort of integrate new information and tools into health pathways, and then it seems to spread. And we're actually not quite sure how it spread, but I did speak to someone who was in charge of the original one, and she had been promoting it as a sort of exemplar health pathway for CVD prevention that was then adopted by other PHNs. So they were sort of relatively easy wins, ways to sort of get a web-based CVD risk assessment tool out into the world, and hopefully to the GPs who need to use them. And then we had our higher resource options working with clinical audit software. So this gets quite complicated because the general practice software market is really fragmented. So it's not like hospital systems where you've got one system, in some cases, that you can sort of very quickly implement something across a large number of patients. So we're working with private businesses. They can choose what patient medical software they use, and they can choose whether they use clinical audit software. They can use the PHN provided one, but they might also choose to switch to a different one. So the current market leaders are PenCS, Polar and Primary Sense, so there's 3. At the time we started, this PenCS was by far the market leader, but it's changing. So we decided to work with PenCS for the purpose of this study. But once you choose one, you are sort of setting yourself up to only reach the practices that are using that software. So it's never going to be a full solution to just work with one software provider, which means it can be quite costly to redevelop things in multiple software systems. And that's just the way at the moment it is in general practice. But for this example, we were working mostly with PenCS, but a little bit with Polar. And we used one example of a PHN who were already going to be promoting CVD risk assessment as part of their PIP-QI, that's Practice Incentives Program, Quality Improvement, a federally funded program where practices are actually paid to share their data with PHNs, and in future will be expected to meet quality improvement targets. So it was relatively new at this point. So it was a data sharing exercise that practices could choose to participate in, and PHNs had various ways that they would help the practices produce clinical audit reports and give feedback back to the practices about how they were going. So this is one of the better examples that we saw, where it's got very clear indicators against RACGP guidelines and targets. It compares the practice performance against those targets and has visual cues for how their performance is rated and where they might want to focus quality improvement measures in future. So altogether from our interview participants, we received examples of 9 audit and feedback reports across quite a range of health topics, but sometimes including CVD. And we compared those to best practice or evidence-based features in the audit and feedback literature. So this was using a checklist developed by Denise O'Connor, an audit and feedback expert in Monash. So what we found, I won't go into this graph in detail, but where it's green, it's meeting or including the feature, and where it's red, it doesn't include the feature. So most of the audit and feedback reports did provide things like recent practice data using visual information, often using some comparison either to the PHN as a whole or to the practice's previous performance. So that's all in line with the evidence on what can change health provider behaviour, but there were lots of features that were missing as well, particularly action plans and ways to address barriers to the feedback provided. So audit and feedback reports are part of what PHNs do, and we can use those to focus on improving outcomes around the new guidelines, but we could also be doing a bit better in terms of the format of the reports. And then the final high resource option was integrating our web-based risk calculator and decision aid with medical records. So there are various ways that you can program software to auto-populate a web-based tool without actually sharing the patient data outside of the medical practice system. So in this case, we've used PenCS Top Bar, literally the black bar at the top, and all the GP has to do when they have a patient record open, so this is a fake patient record, they just have to do one click on the little app icon at the top and it will auto-populate both the risk calculator and the decision aid interface. So we had programmed this previously in our separate partnership grant, but we used the MRFF funded project as an opportunity to actually test the feasibility of this in practice. So the feasibility study was conducted during quite a difficult period of COVID. So practices were quite overwhelmed with staff shortages, secondments, vaccine rollout and the change to telehealth. So although we had 11 practices interested in principle, we ended up only having 4 able to participate over the study period from July to November 2021. But we did get another couple of practices who were using an alternative software system, Polar. So altogether we were working with 6 practices, but at a fairly challenging time. So what we did is basically combine those 2 high resource strategies to see what effect it might have in practice, although in a fairly limited sample. So as well as the Top Bar app, we were also providing monthly practice data in the form of a PIPQI report or PIPQI style report, but we hadn't included those extra features such as action plans that the evidence suggested would improve behaviour. So I'll move on to the next one. This was sort of our recruitment pathway. So case study 1 is the PenCS practices. Case study 2 is the Polar practices. So we only had ethics approval to do the data extraction for the PenCS ones. So from 9 initial practices, we had 3 that successfully used the app and received the monthly practice reports. And then we had an additional 2 Polar practices who just received the Top Bar app access. So that was sort of the idea of that, was that we would sort of try a double high resource strategy and a single high resource strategy and see if it made any difference in a limited number of practices. So altogether, we had 13 general practice staff, 5 practices and 2 different software systems involved in this study. And we extracted data just from the PenCS ones from the period of July to November 2021. What you see here is the actual number of uses of number of times the practice is engaged with the Top Bar app. So you can see it's very variable, ranging from 0 times for the Polar practice 1 to 725 times for PenCS practice 1. So highly variable use, but in total we were actually pretty happy to get 865 uses of this app during quite a challenging COVID period for general practice. But the high variability shows firstly capacity issues, but also that further support is needed beyond those 2 already high resource strategies to actually get practices engaging in this consistently. In terms of our sort of primary outcome that we were trying to influence. It was complete CVD risk assessment data. So there's no way to directly measure whether practices are doing absolute risk assessments because it's through separate tools that are not consistently recorded in the medical records. So the best you can do is see if you have recorded data for things like blood pressure, cholesterol, smoking and diabetes for eligible patients seen recently. So we looked at patients seen in the last month over this period and looked at complete risk assessment data just for those patients. And as you can see, it's very flat. So we sort of had a glimmer of hope with the light blue one. They were the first ones to actually access the app, and it looked like their outcomes were going up for the first 2 months, but then it came back down. So there wasn't much going on there in general, but probably the most important thing there is that the complete data for these practices is already actually quite high. So it's about 60 to 95% complete data. 95 is enormously high. So the average in the most recent PIP-QI data is below 50. So these practices were already quite engaged and probably not actually the ideal practices that you would want to support with a high resource strategy. So overall, we had significant disruptions to general practice from COVID-19 at this time, but the feasibility study showed us that a stepwise trial wasn't going to be feasible to run on a larger scale during the pandemic. So it was actually very useful to do this exercise. The highly variable use of the app shows more support would be needed to implement it consistently and show effects on quality improvement outcomes. And the complete CVD risk assessment data, as I just mentioned, was actually quite high in this sample. But on a positive note, we were able to show that those practices that did have high app use actually maintained that engagement for another 6 months. So we didn't provide any further reports or very much contact support, but they actually continued their use of the app if they had established that in their practice. So conclusion from this is we were able to show it's feasible to integrate patient decision aids in general practice software to improve integration with workflow, which was a key issue identified in our earlier co-design work. But it's not clear whether it would actually be cost effective to use these high resource strategies for the new guidelines, particularly given the changing and very fragmented software market. So you'd have to pick one to start with, and then you're not going to reach all the practices, or you'd need significant resources to develop this type of integration app in multiple systems. So probably targeting lower performing practices with additional support might be a better strategy than providing mass access to an app like this. And I'll just move on to our final study. So in the last part, again, some COVID disruptions, we originally aimed to do a national GP survey to look at use and attitudes towards these different PHN strategies, but our RACGP collaborators advised that it wasn't a good time to do a GP survey with everything going on with COVID, and we probably wouldn't get a very big or very representative sample. So instead, we worked with our collaborators in Tasmania who had been doing interviews around CVD prevention as part of their IDEAL study, and this was prior to their intervention. So it was sort of a good data set to look at general attitudes and management of CVD prevention during COVID and in a state that at that time hadn't been very affected by COVID. So we got access to these transcripts and were able to compare the results to the original GP interviews we did in 2012, where we had identified 5 different ways that GPs were doing risk assessments, and we could compare that to what was happening in this new sample. So just quickly, we had a range of gender, age and years of practice, and again used a framework analysis method. All of these participants were in Tasmania, which at the time hadn't had very large COVID outbreaks. What we found was that all 5 of the risk assessment strategies we identified 10 years ago were still being used, and I'll go into those in a bit more detail on the next slide. Except that lack of awareness and access to risk calculators no longer seemed to be an issue. So that was an issue when the guidelines were still new. There were also some new issues, such as interest in more personalised risk assessment methods, or what the GPs perceived might be a more accurate way, using things like heart scans. Inconsistent management was still a big issue when we presented the GPs with hypothetical cases, and health literacy and communication challenges were still raised as an issue as well. So overall, not very much had changed in this sample compared to the GP interviews that we ran a decade ago. So just to explain those assessment strategies a bit more, if we had implemented the guidelines perfectly, all GPs would be using an absolute risk focused strategy. That means they're using the risk calculator as their primary method of risk assessment, unless there's other indicators to show that the patient is already high risk. Instead, what we tend to get is variations on that in an attempt to try to take more risk factors into account. So there's definitely a perception that this risk algorithm is outdated. There are so many more risk factors that we know about and they need to account for them in some way. So there were variable ways to do that. One was absolute risk adjusted. So it's where you sort of start with an absolute risk calculation, but then you adjust it up or down. So this example, oh, but they're higher because they've got obesity and they've got this as well. The problem with this strategy is that sometimes those risk factors are already taken into account in the model. So in this case, obesity is in the framing and model, but it is already accounted for through blood pressure and cholesterol in the final calculator that we're using. So by adjusting for obesity, you're actually reducing the accuracy of the risk assessment. There was also, sorry, I'll just skip back. Clinical judgment was also an attempt to take these extra factors into account, but not using a risk calculator at all. So again, it comes from a good place, trying to take a more holistic perspective on the patient situation. But we know from quite a few studies that if GPs use this approach, they miss a lot of the high risk cases that are not obvious. So people who have several moderate risk factors don't necessarily look high risk, but when you add up all those together in the calculation, they actually end up being high risk and could benefit from medication. Then we have various ways that people would disregard the guidelines. In the first set of interviews, that was often because they were just in the habit of treating blood pressure and cholesterol as separate risk factors, and they hadn't had a chance to use the new absolute risk calculators yet. In this set, everyone was aware of the calculators, but there were still people who were focused on individual risk factors. So in this case, it doesn't matter what their cardiovascular risk is, there's other things that it's important to treat their blood pressure for. And sometimes that's warranted if the blood pressure is very high or there's other risk factors present. But there was an attitude amongst some GPs that the absolute risk calculation was kind of pointless. And then we had active disregard, where GPs just wanted to do something different altogether. I prefer to go on people's personalised risk, and I think that the coronary artery calcium score really lends itself to that. So this person was very keen on referrals to cardiologists, and actually this type of score has been proposed in the draft guidelines as a way to reclassify risk for patients where it may be borderline or there's other reasons to suspect that the absolute risk calculation isn't accurate for them, but it's not generally recommended as a first-line way to assess risk. So conclusion from this set of interviews, GPs do still need education support for CVD prevention, particularly to explain the role of different risk factors and to integrate assessment and management guidelines in a clear way. And communication had come up again as a need for GPs. So patient communication aids should ideally be integrated into the clinical tools, so GPs aren't having to take extra time to find that information when they do the risk assessment. So that's sort of the end of that program of research. I'm very focused on the role of PHNs, and we've got several sort of follow-up studies planned. So we're working with the Heart Foundation on an SMS recall trial for heart health checks. So that's going on now with 200 practices, and that's quite a new way to sort of implement CVD risk screening in Australia. We're also looking at the consumer side of things, developing a heart health literacy toolkit that addresses health literacy needs for the average person, but also builds consumer skills. We're working on shared decision-making resources with Aboriginal and Torres Strait Islander communities and health workers, So that's also working with the Agency for Clinical Innovation, who've developed a really interesting shared decision-making model in consultation with Western New South Wales communities. So unlike the shared decision-making model I showed you at the start, which was very linear, this one is circular and it includes extra things to consider, such as the role of family and culture. So we're really excited to use this model to produce something quite different. And finally, my dream after COVID is to be able to do a big adaptive trial where we can actually test the relative impact of these different low versus high resource strategies. But it requires a more stable general practice environment because you have to be very precise with the implementation timing to do something like that. So I hope we'll be able to do that in future when COVID settles down. So in summary, we know that CVD prevention could still be improved for over half of Australians, and the new guidelines next year do present an opportunity to address this in a more coordinated way. Primary health networks have played varied roles in supporting prevention when financial drivers and priorities permit this. So we need to be aware of how that is driving their activities and how we can sort of fit into their business as usual processes. And the implementation of the new CVD guidelines could be integrated with existing PHN education, quality improvement and software programs if we coordinate that in time for the new guidelines to be released. So finally, I'd just like to thank my very big ChatGP team who I've been working with for the last 5 years on this topic and our funding, particularly from the Prevention Centre, who received MRFF funding from the Department of Health for this work. And I'd just like to thank the Prevention Centre for their support and the opportunity to present today. Thank you very much.
Carissa, Sam, thank you very much for that very comprehensive overview of the different studies. We do have a couple of minutes for questions. If anybody wants to type something into the chat, we'll try and answer it in the time available. Are you aware of any articles that give overview of different GP software? It sounds like a minefield, and you're absolutely right there, Hannah. It is. Whether Carissa and Sam can provide any other pointers in relation to whether there are actually any articles where people have tried to look at this systematically.
Yeah, I actually haven't come across any, but there is a group at Menzies, a primary care data expert group, who are trying to sort of map this out at the moment and also map GP data assets. So Hannah, I can, if you want to get in touch with me, I can share any reports that that group produces, but that it still seems like it's just, if you know the software market, people sort of talk about it informally, but I haven't seen any formal publications on it.
So, you know, I think, you know, one of the things, Carissa, for me is that, you know, we seem to keep on coming back to that slide that you had towards the end there about the ways that doctors and others, for that matter, can sort of dismiss the absolute risk approach for a whole range of reasons in that regard. And you know, you obviously have tried to make that as easy as possible for them, but it does seem to be there's something else there that I think some of your earlier research points to the challenges in this space.
Yeah, it's a bit of a real sort of conflict between trying to make the risk assessment tools as simple and quick to use as possible, because you need that in the reality of general practice, especially if you're doing opportunistic screening, when a patient might have come in for something completely different and you're just trying to fit in a bit of CVD prevention at the same time. It's got to be really quick. But in doing that, for example, dropping obesity out of the risk calculator because the effect is already accounted for by blood pressure and cholesterol, you need to be really clear about the role of those dropped risk factors, or actually clearly explain that, look, you could include this, but it's not going to add any predictive value to your risk assessment. for GPs to feel comfortable with that, because they have to trust the risk assessment, and I think they don't trust it when it's too short. So hopefully, so the draft guidelines were out in September, and they're based on the New Zealand PREDICT model, and there's several versions of PREDICT that you can use. If you can sort of use a shorter version if you're short on time or data, or you can use more comprehensive versions and different versions for different subgroups. So hopefully that to some extent might address that trust issue.
Okay, well, I can't see any other questions in the chat, so if we don't have any more, then it just leaves me just to say thank you very much on behalf of everybody who's joined us, and on behalf of the Partnership Centre for the great work that you've done in this regard. I know that both Carissa and Sam will be happy to take your emails if you've got more specific